Welcome everybody. Welcome to Physical Disabilities Australia's Fair and Accessible Healthcare webinar. My name is Jeremy Muir and I'm the CEO of Physical Disability Australia, and it's really wonderful to have you join us for this really important, informative and topical presentation. I'd like to begin on behalf of PDA by acknowledging traditional owners of the lands in which we dwell, and we pay our respects to elders past and present. I'm currently coming to you from Turrbal and Yagara land. PDO also acknowledges people with disability, past and present, those who are living full and complete lives, and those who have needs who are not yet being met. We ask you to reflect on this and to work with us to bring about the changes that will give all people with disability an opportunity to live an ordinary life. Once again, welcome to tonight's presentation. This discussion will explore healthcare inequalities faced by people with disability and examine ways that policy change, training systems, and accessible equipment and service provision can be improved and may fare in Australia. This webinar will reignite the conversation and provide important insights for people with disability, the healthcare sector, service providers, and the very systems that need to hear what's truly happening and what needs to be sorted out now. People with disability are not often on an equal playing field to their able-bodied counterparts in regards to healthcare accessibility and fairness. Throw in the curveballs of potentially higher costs resulting from often more frequent needs to access GPs, specialists, and the hospital sector, and often exhaustive need to justify these expenses and the potential long waits for services, and we're looking at healthcare that is frequently exposed as being inequitable. This unfair provision potentially also includes local unavailability of healthcare and medical providers, equipment that fails to address accessibility requirements, and even the attitudes, compassion, empathy, and education of the professionals overseeing patient care. All too frequently, we hear that people with disability are having their healthcare requirements overlooked, with equipment and training failing to meet the needs of many varied health-related experiences in a system often designed to cater for the majority at the expense of the rest. Recent feedback from the disability community, brave shares by social media, and research around screening, treatment, procedures, their suitability and accessibility, highly overstretched public health systems which are failing people with disabilities, significantly affecting life expectancy and quality of life. These instances have all steered us to run a webinar around accessible and fair healthcare, with contributions from people who have encountered challenges and unfairness, professionals within the sector, government representatives, and academics in the disability access space. Our panel of expert speakers will bring a wealth of knowledge, understanding, and experience to this conversation, exploring what is and isn't working in Australia's healthcare system and medical systems for people with disability. Our first speaker, which will probably be known to many of you, is Dr. Dinesh Palipana OAM. As a frontline medical professional working as a principal medical officer in the emergency department at Gold Coast University Hospital, Dinesh's understanding of the medical system, its resources, capabilities, successes, challenges, and shortfalls will provide a thorough overview of what needs to be addressed to improve services with people with disabilities. Over to you, Dinesh.
Thanks, Jeremy, for the very kind introduction, and thank you everyone for joining us this evening, and thanks to our friends Carol and Mandy and Natasha and everyone from PDA who's made this possible. I was a medical student in 2010 at the age of 25 when this car accident happened, and within seconds I was paralyzed and I had a spinal cord injury. It's with some, well, concern, I suppose, that I say that when I was a third year medical student at the time, I really had no idea what the experience was like for a person with a disability going through the health system. But I was thrown into this life as a patient, and I spent the next 8 months in the hospital. I love going to work today. I'm going to work tomorrow. I'm going to be working through the evening. Actually excited. I look forward to the work that I get to do. But I hate going to the hospital as a patient. I'm fearful of it. I try to avoid it, and I don't go to a hospital unless I'm dying. And the irony of that is not lost on me. And I think the big reason for this is because in the 8 months that I spent in the hospital with a spinal cord injury and the many weeks that I spent off and on over the next couple of years was so disempowering. It was so terrifying. And some of the most basic needs were not met. I've laid in my own waste for hours and hours. And when I was working with the Disability Royal Commission, we found that people experienced all kinds of violence, neglect, and abuse in the healthcare system, including sexual violence. And I have experienced all of these things in my time as a patient. Hospitals, sadly, have a long way to go before we make them accessible, inclusive, and caring for people with disability. And I've got to say, in a hospital local to me, someone with an intellectual disability passed away from starvation just a couple of years ago. These things are still happening in our hospitals, and we need to be a voice to bring about the change. Fortunately, I was able to push through, and I think this experience made me want to become a doctor even more. And so I graduated from medical school, and it's been 9 years since I've been a doctor. So what do I see and what have I learned? I think still we have a long way to go in providing even basic things like good wheelchair access, making everything inclusive and accessible, including information, making sure that carers can be present and families can be involved. These things are not universally present in all the hospitals. I think most concerningly and most importantly, what we need to change. Sure, I think the physical environments are important. I think making sure that doors are automatic, making sure that ramps and access are there physically. But I think most importantly, what needs to change are attitudes. I got a text message from a colleague, actually a close friend, just a few weeks ago. They're a specialist in a particular area of medicine. And you'd be surprised at what the message was. It was, how do I stop patients from electric wheelchairs from coming into my clinic because they're damaging all the walls? Is there a legal basis for me to do this? And I was a little bit taken aback that my friend and very senior colleague would ask me this question. But it also highlighted this barrier that we have, right? Because it's really, is it actually the physical environment that's the problem here, or is it the attitude? I think it's an attitude issue, right? And I think these attitude problems are leading to much of the challenges that we have. There are segments in healthcare where even things like quality of life judgments are made about people with disability. One example was during the COVID-19 pandemic, and I think this is an important time for us to talk about because it's when everyone was stretched. And I think this was the time when a lot of the problems came to surface. And at the start of the pandemic, I was really dismayed to look at a guideline that came out in the US at the time. And one of the first questions in this guideline, which was a decision-making tool about whether someone would get intensive care and a ventilator or not. One of the first questions was, does this person have a significant disability? If the answer to that question was yes, then you could go on to make decisions about them going to palliative care or not getting a ventilator or letting nature take its course. It's concerning, right? So what is the biggest thing that we need to change? I think in the system, currently, we're still experiencing barriers in the quality of healthcare that we receive. There's still barriers in the life expectancy gap, and it's not equitable currently. But I think if we are to get to the root of the problem and address the root of the issue, it is changing attitudes. I think a lot of the physical challenges, I think a lot of the access issues, I think all of that can be overcome if the healthcare system had the right attitude. I'm going to leave you with one little point on that. I have a friend and a senior colleague who is an intensive care specialist, and he's taken a bit of time out from work at the moment because he's a bit dismayed at how the system is, how it's looking after our patients and also our colleagues. But he took the time to share with me a book called Compassionomics. And this book goes through our healthcare system, and it's a damning condemnation of how compassion is lacking in the healthcare system. And actually, if you look at some of the statistics, many healthcare providers are burnt out and have compassion fatigue. But it also goes on to say that if we're going to fix some of the access issues, if we're going to fix things like life expectancy, if we're going to give people better outcomes, even in things like pain, the evidence for compassion is huge. So hopefully, as we move this forward, we can be a voice from the outside to bring that compassion back for people with disability in the healthcare system, to have those conversations. But hopefully, we can start inserting ourselves within the healthcare system as well, because I think that is critical. So I'm going to hand you over to some of my most favorite people in the world, like Carol and Mandy. And thank you for giving me a few minutes of your time tonight.
Thank you, Dinesh. That was wonderful. And I think as a person with a disability who's obviously been in touch with the health system many times, I think that message around compassion and compassion with understanding around being a person with disability is what you really seek when you have contact with the health system. And I think most of us know when it's not there, and you can feel when it's not there, and you sometimes continue on that journey with those health professionals when you would rather not, but you don't have a lot of choice in doing so. So thank you again, Dinesh. Okay, Carol, the inimitable Carol Taylor. She'll provide personal insight into healthcare provision with a background in law and as the world's first quadriplegic fashion designer with adaptive fashion and inclusive design. And Dinesh has been one of Carol's models. Carol is already positioned as a strong disability advocate working towards positive change for Australia's disability community. However, recent issues around her own health have amplified her passion for making things right in a healthcare system that needs to address the accessibility and patient-centered care for people with disability. Over to you, Carol.
Thank you very much, Jeremy and Dinesh, for that lovely intro. And I would like to thank Physical Disability Australia for this invitation. I feel very honoured and grateful to be here, especially amongst such esteemed speakers. This means a lot to me on so many levels. I have 24 years experience as a quadriplegic. I had my own law practice in Sydney at the time of my injury. I was a newlywed. My husband and I was trying to start a family, and everyone was encouraging us, get away for the weekend and relax. So we did just that, and we're coming home. We decided to play hooky one Monday morning instead of going home on Sunday, and we drove through the Blue Mountains at 7 a.m. and we hit black ice, which you cannot see, of course, being black, and the car rolled, and on the second roll the roof came down, hit me on the back of the neck, and instantly severed my spinal cord. There was not another mark on me or Rob, who was driving, and not a scratch. But I was taken away, paralyzed from the neck down initially. I couldn't move my arms. I thought they were just broken. At the time, I didn't realize that I was a quadriplegic. I was taken off to hospital, airlifted, where I would spend the next year. And in that year, I really experienced some horrific access to healthcare. There isn't time to go into everything and cover it all this evening, but just to touch on a couple of things. I had abuse of one of the nurses that he was himself, I since discovered, and I had issues, and probably shouldn't have been with the health system, but the NUM was of the view that they were so short of staff that anybody was better than nobody, even if he was just to help moving furniture. And his punishment to me, if I complained about him, because I naturally became a bit of an advocate on the floor, patients would come to me and ask me to advocate for their needs. I could hear women through the curtain beside me crying, and the mistreatment that was going, the way they were being yelled at, and so on. And so I did begin to advocate for them, and became a bit of a troublemaker, I guess. But this nurse's way to punish me was I would wake up covered in urine, covered in my own urine. He would undo the tap of my catheter on my thigh at the time, and I would wake up covered in my own urine. And he would then quietly let me know later that he was responsible for that, and that if I did so again, it would happen. And it did happen. Even when I complained, that's when I was really dismissed. There was another occasion where a young doctor had sent me across for surgery to have this SPC inserted, and the night before, my temperature had been over 40, and when I got into the surgery, I was asked a series of questions last minute by the nurse, and they asked about, has your temperature been above a certain, and I said yes, it's been 39 whatever, and the surgeon started yelling at me and abusing me and sending me back, and I didn't know what was going on. So it was a terrible experience, and I was in there for a year. That was rehab, Prince Henry Rehab. They've pulled the place down since in Sydney, and that's exactly what they should have done with it. Then I went into acute care, and that was, into rehab and all the rest of it. And there's a lot more, there were good parts and bad parts. I awoke to be told I would never walk again, and I didn't have a family member with me. I just had this strange nurse deliver this news to me by myself, and I couldn't talk or communicate. The only way I could communicate was to blink my eyes. I eventually got permission from my husband and nurse sister to bring in alphabet letters and try to communicate with the staff, and I'd blink to letters of the alphabet. It was very hard back then. This was 2001, so I'm sure things have changed. But I came home, and then I had home staff, and I had one lady that was going through a difficult time in her private life, and I was struggling to learn to paint initially with oils, and my husband had adapted all these brushes for me to do that. Plug me in. And she put in turpentine, what you call odorless Turks, into my glass. I drink from a pint glass, and she was I drink from a pint glass, which Miraculously, due to tenodesis in one thumb, I'm now able to hold a large pint glass, and yet I can recall the tremendous moment in hospital when this hand held an empty polystyrene cup for the very first time, and my whole family burst into tears. And it was an empty polystyrene cup, and now I can hold a pint glass full of water and drink through a lot of that, 2 to 3 liters a day. So where I've moved from that experience and rebuilt my life, largely with the support of my husband and son. A son, I was told I would never be able to have children because of a number of reasons, but quadriplegic was the nail in the head. And we proved them wrong there. But then there were added complications in art, mental depression, PTSD, anxiety, all of that. And it was really art that helped me. My husband helped me to discover art. I thought he was crazy. I've got paralyzed hands, but somehow I did. And then I detoured. My son was 8 years old. I returned to law. I'm still a lawyer, but I haven't been taking on clients of late. The last 2 years, I was very much involved in my fashion career, which I hope somebody knows something about by now, with having Dinesh as a model. And that ended rather badly, but I love and still have an excellent passion to pursue this in some way. But this year railroaded me with this complete shock of me pushing my way through to get, I made an appointment in 2024 with a private imaging clinic. I explained and fully disclosed my disability. The receptionist was very good. She asked all the right questions about my wheelchair. She relayed it to the relevant person that would be doing the imaging, and the appointment was accepted. Then days before my appointment in 2025, I got a phone call to cancel on the basis that I must be able to perform a standing transfer. At that time, there was no mention of me having to have an ultrasound. I was only booked in for a mammogram, but the standing transfer was the requirement. So I was a bit gobsmacked, and so really just said, okay, and thought afterwards, this can't be right. So then I rang a number of other places and was starting to get a similar storyline. And I went public and private with my inquiries, to be fair, to find out. And it was pretty much, I was getting pushback everywhere. So then I rang like the closest one to me, which was Breast Screen Queensland. And then that's when I pulled out my lawyer hat and said, well, actually, it's against the law, particularly in Queensland, as we have our own legislation here that makes the delivery of goods and services a requirement, that it must be equal to all. And then the attitude changed a little bit, and they said, look, well, come on in and let's see what we can do. So we got in there, and honestly, it could not have been better. I have nothing but praise for Breast Screen Queensland and the staff. From the moment I got there, the facilities were fantastic. The attitude of the receptionist, the staff, the room was huge, plenty of room in there for equipment. Now the equipment, I'm in a power chair, and I realize every disability is different. So I'm only speaking for myself. I wouldn't presume to speak for others, but my chair can go, I think, up to 6 foot, and it can also lay me completely flat. So when I went in there for the scan, I was able to elevate, and I was able to I had permission to bring my husband, and he was able to assist, which was needed because the arms of my chair need to be lifted out of the way. And then we reduced the chair to the lowest speed, and then he could inch me forward and help to position my breast where it needed to be. And they can squish and do whatever else they needed to do to get the appropriate scans. Now, I think after that, I wheeled out of there thinking, okay, this is just something I can tick now as I've done it, because I'm on the other side of 50 now, so this is good. Do my checklist. And 3 weeks later, when I got a recall, I thought, is this something to worry about? And I went to their website, I was sent a link, and I was told, look, this is common. So I really wasn't worried when I went in, but boy, was I pretty worried and shocked when I got in there, because a doctor was in there as well to deliver, a surgeon, I believe, a surgeon, yes, to deliver the news that they straight away put me on turned the wheelchair into a bed essentially, and they did an ultrasound of the lymph nodes. They took 3 biopsies, and I got the results back very quickly that the first 2 biopsies, I was told by the doctor, were what they call garden variety cancer. So this is the best kind of cancer to get, and they're fairly confident the 3rd biopsy will come back garden variety as well. And so that should give me some bit of comfort. And so really what I'm looking at is about a year of my life where cancer will interrupt the hair loss, the medication, the backwards and forwards for hormone treatment, yada, yada. So I'm like, okay, in shock, but this is stage 1. I've caught, this is good. Only to find out after an 8-day wait, which is an extremely long time when you're waiting to find out is something aggressive or not, to get the unexpected news by everybody that the tumor was in fact aggressive. And I don't have a family history of breast cancer. I don't know where this came from. There's no family history. There was no lump on my breast. There's absolutely nothing to indicate the presence or that I should even be on their guard, except that I just, that number 50 stuck in my head that, okay, you got to do this stuff after that age. What I found was that, this pushback was not good. And what's more, we had a real patchwork approach nationally. Every state seemed to have its own philosophy on what this should be. Some were welcoming of electric chairs, some definitely didn't want us. And I've spoken to colleagues and friends of mine that are in manual chairs, and they also say that they can manage. One, in fact, has a private clinic that she can attend in Brisbane, that she says it's a private hospital, I believe, and they're trained, and she has nothing but great things to say about them. So I've no doubt there's yin and yang. I've no doubt there's plenty some that can do, some that can't. But we really should not be a lottery. It shouldn't be a postcode lottery, and it shouldn't be this inconsistent patchwork approach. We need a national protocol, guidelines issued across the whole country. This is how people with disability, dexterity issues, and eventually the elderly, because eventually that's where we're all going to end up. I've got some statistics that whilst, I think we've got like 18.5% of Australians with disability, 21.8 are over 60, projected to be 26% by 2031. And then in between that, you've got countless others at any given time suffering from mobility challenges, injuries, accidents, all the rest of it. So it's like the old adage, right? What benefits disability benefits everybody. So we really need to try and get a wake-up call into the right heads to do something about this. So I guess that's where I got when I wanted to go public with my own story, and got the ABC involved with the wonderful Naz Campanella. And it's not, equal access to goods and services is not a luxury, it's the law. And we need to get them on board, and we need to shake it up. And thank you to PDA for helping me do that. Having said that, I do want to praise the wonderful treatment and care that I am getting from so many, like the care I'm getting at the moment through Breast Screen and through GCUH Hospital here is second to none. And we are so lucky. I second what Dinesh says. We are so lucky as a country, especially when you see what's going on overseas. We are so fortunate. I say it every day. And I'm so glad to have this. Whilst most people might be saying this, say sorry, and this is terrible, to me, this is great news and a great start to 2025. Because although, losing hair and eyebrows and all the rest of it is no picnic, it's great news to know, because imagine the alternative of not knowing, and to achieve all I have achieved since my injury and built a wonderful life for myself including a family, and then to lose it all. I could potentially have lost it if I discovered at stage 4, all through negligence and or not just availability. But I couldn't agree more. It's social bias that needs to change. You know, this is all about people's attitudes. And I have to say that I have, since the ABC segment, I have heard from Loomis. I have had an apology, and they do seem, I'm very much encouraged and warmed by their taking up of my offer to become involved, to offer advice and help in the advisory group that they're putting together. And they do seem to be very genuine in wanting to make a commitment to be, I think, first movers and to be a shining light in this area and to lead for others, which is a great thing. It can only be good. So thank you. And I can't thank you enough for bringing this to everyone's attention. Thank you.
Thank you, Carol. And you raised so many good points there. If you had decided, oh, I won't worry about it, or I'll wait till next year, or oh, I can't be bothered at the moment, how the outcome could have been so much different for you. And the issue that you raise around that inconsistency of where you can go, you know, you're right. It shouldn't be a postcode lottery. We should be able to choose the healthcare we want by the quality, not by can I access that or can I get in or do they have the equipment? And the fact that you didn't know what was going to happen until you got there and then it worked out okay going to you shouldn't have to get there and not know that it's going to be okay. And you're right, we do have compared to many other places, we have a great health system, but I think for those of us with disabilities, we still have a way to go.
Yes, couldn't agree more.
Thank you. Thank you, Carol.
Thank you, Jeremy.
Okay, so our third speaker for tonight is Mandy Frier. Mandy is the Access for All Disability Awareness for Health Providers Manager at CheckUP Australia. Mandy's background in nutrition and dietetics.
Yeah, that's it.
Yeah, and lived experience have seen her on the giving and receiving ends of healthcare with people with disability. This dual exposure to healthcare for people with disability has helped to understand the importance of disability awareness among health providers. Mandy strongly believes that providing healthcare which is fully inclusive and accessible beyond physical access is an essential first step for all health professionals. Her PhD on social determinants of health reinforces her commitment to true health equity for all. Mandy, over to you.
Thank you very much, Jeremy. Thanks everyone for letting me speak, and thanks to PDA for inviting me to speak as well. So as Jeremy said, I am a dietitian and I also have a lived experience of disability. So I have a neurological condition which I acquired as an adult after I had done my dietetic training. So the neurological issue sort of affects my balance and coordination and sensation, mostly on my right side, but a little bit on the left, and a few other things as well. And the consequences of that mean that I use a wheelchair for mobility. And so I guess my experience with healthcare as a patient is quite long. So I had about 3 or 4 months as an acute patient, but then I was an outpatient for almost 3 years doing rehab. So I feel quite familiar with the healthcare system from both perspectives, as Dinesh sort of does as well. And so my experience, whilst not as traumatic as Dinesh, hasn't always been good, but there has also been some good things about that. So I'd like to talk about that. So I'm not going to talk about any of the distressing things that have occurred today, but I do really acknowledge and understand, completely agree that there is a long way to go before improvements are made. So I guess probably a little minor thing that we as health providers can do is just change our attitudes, like sort of Dinesh alluded to. So some little things that affect my healthcare accessibility is writing. So I can't write properly. So that means I can't fill in the forms properly and those sorts of things. And whilst they're really minor and they have minor effects, those minor changes can make big changes to the person with disability. And so I often wondered, because my experience with healthcare professionals was relatively good, I often wonder, was it because I was a health provider myself and people therefore were at the top of their game? So I'm not really sure about that. But I'm fortunate enough to say that it hasn't all been bad, but there's definitely a long way to go before healthcare is truly accessible and fair for people with disability. And I think for sustained positive change to happen, there needs to be systemic and policies and governance that support this. However, from the ground up, as a health provider, I feel that we can do something as well, and that's really about disability awareness, and it's kind of a good place for us to start, and it means that we can take action, you know, to make the positive change that's required to improve the healthcare system. And so it doesn't have to necessarily be only with health professionals. It can be with reception staff, assistants, and even cleaners. But of course, we as health professionals are pivotal to improving the healthcare experience of people with disability. I guess, though, what I do know, I like to think that no healthcare professionals, no matter what their discipline, wants to do a bad job. I like to think that everybody wants to do a good job and take the best care of their patients as possible. However, due to lack of disability awareness, sometimes they don't know what to do, or they don't know how to do a good job. But even worse, and probably this is where the problems start, is that I guess sometimes health providers think they're doing a good job and they're actually not. And this has become where things become problematic, and it's where you know, things become life-threatening and dangerous. But as I said, I don't believe that it's on purpose. I just think it's a lack of awareness, or perhaps distorted understanding, and the lack of asking, and perhaps some of our hidden biases and assumptions that make things a little bit more inaccessible for people with disability than they have to be. So when we talk about disability, and Dinesh sort of spoke about this, it's more than just physical. It's really about the attitudes of the health providers that will really help. And so it means when the way we talk to people with disability as a health professional, how we communicate and understand other people's communication, the assumptions and biases we might have. And those things can all get in the road of a person with disability having an experience that's fair and equitable for them to access healthcare. And really everybody deserves that. That's, you know, a fundamental right. And so as it happens, this experience has led me to work in my current job at the moment. And as Jeremy sort of said, I'm now looking after Access for All, which is a disability awareness program. So I work for an organisation called CheckUP, and they're a not-for-profit health organisations. And I guess their overarching philosophy is really about health equity for vulnerable populations. And so in my case, it's for people with disability. So we were successful in receiving the funding about 5 years ago now. And we've developed an online course in very, very heavy consultation with people with disability. And Dinesh was very integral, I guess, in helping us develop the course, but also disseminating it throughout Queensland and Australia. And Carol also helped us out by being a speaker at one of our launches. So we're very grateful to both of those people as well. However, there was also a lot of other people with disability involved in the development of the course, and it was very much based on their lived experience of disability, but also their experiences within the healthcare system. So it's a very, very preliminary step, and as I said, lots of systemic changes need to occur. And as the title says, it's just access for all, disability awareness for health providers. And it's not about any particular disability, and it's not specific to any health profession. It's just about creating awareness, and it covers things beyond physical access, so like communication, assumptions and biases, and it helps people, I guess, the way they work with people with disability to improve the quality of care that they provide. And as I said, I really like to think that all health providers hope to provide the best possible care they can, just need to be helped sometimes to understand how. So I guess what we're hoping is that some of the barriers that people with disability experience when they're accessing healthcare can be reduced just by creating awareness. And as I said, there's lots of systemic things and policies that need to be in place, I guess, to make that environment, to make people's environment that they work in, to make it accessible for people with disability. But if you're interested in doing the course, I've emailed the flyer to Natasha, and on there is a website and the QR code for access the course. It's free to do. And I'd encourage all health providers to do it, just to start, creating awareness of some of the barriers that we as health providers create ourselves. Just by making small changes makes a big difference to people's healthcare experience. And the course also attracts CPD points, and it's available on the AMA CPD home. So whilst I understand that, people have been through some distressing sort of situations, people with disability have been through some distressing situations, I kind of am hoping that just by creating awareness, there might be just a little start to help realise some of the barriers that people with disability experience when they're accessing healthcare, really. So yeah, that's all I have to say, but I just kind of think, I want everyone to understand that we do know that health providers don't try and do a bad job. They just need to be helped to understand why. And we can all be part of making a really positive change to do that. So thank you.
Thank you, Mandy. And I think you're exactly right. Sometimes it's about that lack of awareness about what is required for people with disabilities, and that and I think all of us are aware that there's very limited specific training around healthcare for people with disabilities provided to healthcare professionals. I think I've heard somewhere that one person who trained got 1 hour of a disability awareness training through their whole degree course. So your course sounds excellent, and I think we'll be able to provide the link to for everyone in that course so they can pass it on to the relevant people. So that would be fabulous. Thank you. And thank you for letting us know about that program. Certainly something I wasn't aware of, but I can certainly make others aware of it.
Oh, great. Thank you. Thanks for having me.
Thank you, Mandy. Our fourth speaker for tonight is Dr. E. Yang, a research fellow with the University of Melbourne. Her understandings and research on health equalities faced with disability. Her interest in quantifying inequalities in the National Disability Insurance Scheme and assessing the potential impact of policy changes in reducing these inequalities. For much of her expertise and as an epidemiologist, E has also led studies examining cancer inequalities among people with disability. Over to you, Dr. Yang.
Thank you, Jeremy, for the introduction, and thanks for PDA for inviting me to speak here today. It's really great to be with you all at this webinar. So as Jeremy mentioned, I'm a social epidemiologist and research fellow. Most of my work focuses on understanding and quantifying health inequalities experienced by people with disability, including how big the gaps are and what drives them and what needs to be changed. So although my work is a lot about analyzing population data, it's part of a broader effort at the University of Melbourne, where as a team, we study both lived experience and numbers, so to build a more complete picture of inequalities faced by people with disability. So today I want to share some findings from my recent research about what happens or the consequence when the health system doesn't work well for people with disability. And that's also what's likely to keep happening if the issues Carol, Dinesh, and Mandy highlighted earlier are not addressed and not set as a priority. So including barriers in physical environment, attitude, compassion, and awareness. So I've prepared a few slides that I can share with you all. Thanks, Natasha. So could you please go to the next slide? And the next one. Thank you. Earlier this year, we published a large study that found people with disability are 4 times more likely to die early than people without disability in Australia. What we did was we analyzed census and death data from more than 15 million Australians up to age 74 years old. Among those who died during the year 2011 and 2020, which was about 460,000 people, we looked at what conditions caused their deaths and whether they had a disability. And what we found was that people with disability were dying at a much higher rate than people without disability from conditions like cancer and heart disease, those conditions that are often preventable or treatable with right actions. Next slide, please. So I want to show you this graph. So this graph here shows death rates in each 5-year age groups for people with and without disability in Australia. Each dot represents the death rate for a specific age group. The lighter pink dots are for people without disability, and the darker blue dots are for people with disability. So as we expected, death rates increase with age, and that's the general pattern we see in both populations. But what really stands out is that it is the consistent inequalities between the two groups. So we can see that across all age groups, people with disability have higher death rates than people without disability. And the gaps actually widens in middle to older age groups, where we see much higher death rates among people with disability. And most importantly, what we found was that often the causes of these deaths were not directly related to people's disability, which I'll show you in the next slide. Thank you. So when we break down the underlying causes of the additional deaths in people with disability, we found that people with disability were dying from conditions like cancer, heart disease, diabetes, and so on. So these are not rare or unusual conditions. They are actually quite common and serious if unattended. So, but at the same time, these are also the kind of conditions that can either be prevented or treated with appropriate care. For example, the risk of developing some of the conditions like heart disease or many cancers could be reduced with things like better access to screening, like Carol mentioned, and inclusive health promotion programs. And many of the conditions could also be treated successfully or managed well if people with disability are able to be diagnosed early, have proper follow-up, and provided with high quality care. So because of all these, the higher death rates due to these conditions in people with disability represent unequal opportunities and missed opportunities to prevent illness, identify them early, and treat them properly after diagnosis. So this tells us that the real issue is likely a health system that fails to provide equitable access for people with disability in Australia. So although we have a good healthcare system, but it's only good when everyone has equal access to it. Can you please go to the next slide? Thank you. So I'll use cancer as an example. In our recent review of global evidence, what we found was that people with disability experience inequalities along the whole cancer journey. So in many countries around the world, people with disability are more likely to miss out on cancer screening programs, And because of this, cancer is often diagnosed later when it's harder to treat. And unfortunately, the inequalities don't stop at diagnosis. The evidence also show that people with disability are more likely to receive poorer quality care, including delays in treatment, being undertreated, or sometimes even receiving more invasive treatment than necessary. So all of these factors add up to a serious outcome. That is, people with disability have lower survival rates and higher mortality from cancer globally. This is not only a problem in other countries, but also a significant issue in Australia. Can you please go to the next slide? Thank you. So our team has now started looking into Australian data on cancer inequality. We've started by looking at which specific cancer types are driving the higher cancer death rates in people with disability in Australia. What we are seeing is that there is a significant proportion of the higher cancer deaths in people with disability are caused by cancers covered by Australia's existing screening programs for early detection, including breast cancer, bowel cancer, and cervical cancer. People with disability also had higher death rates from several other cancers that would also benefit from early detection and better care. We also see a higher death rates caused by groups of cancers associated with modifiable lifestyle factors like smoking, alcohol use, and obesity. So this again tells us that cancer deaths among people with disability are potentially avoidable. Many could potentially be avoided through inclusive prevention efforts, better access to early detection through screening and follow-up, and high-quality treatment and care after diagnosis. So next slide, please. So what I wanted to share through this research is that the data tells us that Australians with disability are more likely to die early than the rest of the population in Australia, often from preventable or treatable conditions that shouldn't really cost lives. So poor health and early death shouldn't be part of having a disability. Instead, most of the time, they often reflect a health system that excludes people with disability. And fair and accessible healthcare will be key to ending avoidable deaths among people with disability. So I hope these findings from the research could help to back up the inequalities many people already know very well from personal experiences in interacting with the health system, and hope the numbers could support the voices of people with disability and strengthen the case for fairer and more inclusive healthcare. Otherwise, poor health and early deaths are likely to keep happening among people with disability if things don't change, those things mentioned earlier. Yeah. So next slide, please. So I want to acknowledge my colleagues who are involved in this program of work, including my colleagues at the University of Melbourne and also researchers from Cancer Council Victoria. And also want to acknowledge Melbourne Disability Institute and the University of Melbourne for funding this research. And thanks a lot to PDA for inviting me to share these findings that I hope will be useful to some of you. Yeah, thank you.
Thank you, E. That was hit you in the face, sobering statistics. And as a over 60 white male with a disability, I worry about my future. And I think that research really lends back to some of Dinesh's information earlier about if they have what is considered a significant disability, then do we provide people with the appropriate healthcare that they need? It's yeah, I'm going to get some checkups, I think, after that. Okay, our final speaker for this evening. I'll just check whether Senator Jordan Still John is with us. I believe he
Oh,
is.
hello
Great.
there. Yes, I am.
Okay. So most of you will know Senator Jordan Still John and share his thoughts on many things that need to change in the Australian healthcare space, and the need to shift to honour lived experience as expertise in streamlining bureaucratic processes and ensuring that healthcare becomes more accessible and affordable for everyone, regardless of income, postcode, or any other identities. Thank you, Jordan, and over to you.
Thank you very much, and thank you first of all to all of the speakers who have shared their lived experience with us this evening. I know this is a relatively safe space, or I hope that people feel that it is, but it is still it still requires emotional labour from us to share those stories and to share those experiences with each other. And to sit, as Melanie just pointed out, in the heaviness of some of those statistics, as they confirm for us what we experience day to day. I want to acknowledge that I'm coming to you from Wajak Noongar Budja in Boorloo, Perth, and pay respect to elders past and present, and acknowledge that sovereignty over this land was never ceded. As we gather online to talk about healthcare, it's really important to recognise that the intersection between disability and First Nations identity is a incredibly difficult space to occupy when it comes to trying to get anything from our healthcare system. I want to do a couple of things in our brief period of time tonight. I want to offer a few additional observations to those that have been set out by the speakers. And I also want to try to offer a bit of a pathway towards hope and action to address some of these dynamics and some of these realities that we see in our community. So first of all, what can I add to what has been covered so fulsomely by our panel so far? Well, firstly, I would very much agree with and reiterate two key themes that I've heard of, three key themes really. Firstly, that when we look at healthcare, we must look at the big picture and consider the social and economic determinants of health, as well as looking at parts of the healthcare system, such as the experiences of those of us that might be within acute settings. And what we see in Australia at the moment is that we have some serious gaps in our healthcare system that exacerbate those social and economic determinants. The absence of mental and dental healthcare from being fully covered by Medicare is one which keeps coming up and up and up from the community, and which I, as a Green and the healthcare spokesperson for the party, have been talking a lot about since Parliament came back together. It makes no sense that Medicare doesn't treat the mouth as part of the body and requires you to be so capped and limited in the amount of mental health care help that you seek through the Better Access Scheme. This affects the entire community. It disproportionately affects disabled people. And as the chair of the Senate Select Committee inquiry into dental access in Australia, in the last Parliament, I was shocked, well, no, I should say angered, but not surprised, to find out that at the time there was only 26 specialist dentists in the entirety of the country that have trained specifically to work with and deliver dental and oral health care to disabled people, including one in my state of Western Australia, none in the ACT, and none in the Northern Territory. It's a situation that is leaving us as disabled people living in severe pain and at risk of so many other flow-through health effects, whether that be dementia or heart disease, further risk in relation to pregnancy. And we must fill that gap in our healthcare system. And we must enable people to seek as much healthcare for their mental health that they may need. It's a moral imperative that we do that. We also know that it is a really smart policy, because if you are able to get in and help people to access oral and dental healthcare, for example, you can make a real dent in the some 89,000 annual presentations to emergency departments across the country due to potentially preventable dental and oral health conditions that have gone untreated. So we can also help our healthcare system in that broader way as well. If we were to do that, and we were also to implement so many of the recommendations that have been made and continue to be made by the Centres for Excellence around intellectual disability in healthcare, the recommendations that have come from the Disability Royal Commissions and from so many inquiries, we could effectively together build a system which on paper would cover the whole body, regardless of what that body or indeed what that mind looked like, that would approach the person as an individual without any preconceived notions of what presentation might look like. Or I should say, some preconceived notions, but a properly informed basis for exploring with an individual what that health condition might look like for them in a particular circumstance. We could, on paper, build that system. To make it a reality for people, what we would then need to do is confront the discriminatory thought process, the ableism that lives at the heart of, or occupies, I should say, so many spaces within the healthcare and medical professions. Now, some of this is to do with that active discrimination and that, you know, very no other word for it, you know, a kind of a hateful and almost, you know, deeply unacceptable treatment towards disabled people, which Carol and others have described in detail tonight. A lot of it is also the subconscious ableism that exists as a result of the historical formation of the Western medical tradition as developing around an idea of an ideal human function and an ideal human functional body, which for various reasons ended up being the functional body and capacity of a white male in their kind of 20s and 30s, and kind of built forward from there with everybody that kind of departed from that medicalized ideal being viewed as somewhat dysfunctional or functioning with a lesser as part of that function. And of course, go back, 100 years, 200 years, and that was much more explicitly talked about. Now it is not so explicitly talked about, though still is in a terrifying extent in some spaces. But a similar thread remains, which is the the reduction of the human being from a human being to a list of symptoms to be treated and managed, often in isolation, with that treatment and management kind of now papered over a little bit with buzzwords like patient-centered care and all the kind of acronyms that dominate modern medical bureaucratic parlance. But still there is an idea that the pinnacle is cure. The metric of success is cure and prevent, cure and prevent. And what we're curing and preventing is that which diverges from the healthy ideal. And that is something that's got to be, and this is a process that's got to be led, and this is why people like Dinesh and others, Mandy, inspire me so greatly. It has to be a conversation led from within the medical community at the same time as those in the general community apply pressure for that change to occur. As modern medicine comes to a new understanding of its role and the way it views the disabled body, the disabled mind, and what it exists to do. And I've actually great faith that the disabled people in those spaces who are coming up now with a fury. I have had so many wonderful conversations with young medical students who just a decade ago, or even 8 years ago, when I started in this role and took my first meeting with the Australian Association of Medical Students, the topic of the inherent requirements that existed as a barrier to practicing medicine in the first place as a disabled person, well, they were on the radar, but they were kind of a bit towards the bottom of the top issues that would be raised. Now the president and the incoming president are proudly disabled women themselves and are part of a generation that are banging down the doors and insisting on their rights to be medical practitioners and specialists and moving in the same spaces as everybody else. So I've quite a lot of hope that that work is underway and can be speeded up so that we do get that cultural shift in medicine, so that we never again hear these stories of disabled people in our community waking up with "do not resuscitate" bands on their wrists that they didn't ask for. Or my office never again has to take a constituent inquiry from a family whose disabled child struggled to get care in a hospital in Bundaberg for literally days because the doctors kept suggesting that they could administer enough pain medication so that they would simply slip away. You know, like there's just horrific stuff that only those two examples just scratch the surface of what the Royal Commission revealed, or indeed what we experienced as disabled people during COVID, when it very much seemed like we were going to be put to the bottom of the queue because we were considered to be less valuable than others in society. So that work is underway. The last bit that I would say is that for these changes to occur, we must bring down the cost barriers and lift the weights of debt that sit upon our community, whether we be practitioners, medical practitioners and professionals, or members of the general community. If you are a member of the general community, the DSP, being as low as it is a material barrier to you accessing healthcare. Because if you cannot afford to get to your location where you would get healthcare, if you are constantly living in financial stress, you do not have the bandwidth to go and get the mole check, or go to the GP, or to do any of these other preventative healthcare steps, even if they did exist and were provided accessibly. So we have to tackle those barriers there. Same with going to see the GP. We still have a situation where it is far too expensive for many of us to go to the GP, or indeed to fill the scripts for the medications that we need as disabled people. It is expensive to be disabled in Australia, and when it comes to healthcare, we've got to bring those costs down. And then for our medical students, we need to eliminate the debt burden that they often struggle under once they leave university, and make it so that they can go and train to be doctors and professionals in medical spaces without worrying about that debt. Hopefully learning from a curriculum that genuinely puts access and inclusion, human dignity and human rights for disabled people at the centre rather than covering it as an optional extra as part of a unit you can do at the end of your course. So with all that said and done, I think I'll leave that there. But thank you so much for your time this evening, everybody. It's a pleasure to be with you and to talk about these really vital topics.
Thank you, Jordan. Thank you so much. I think we're all a little reassured that we have you on our side and we have you fighting the good fight for us in with these issues. And I think most of us will be standing right behind you or wheeling right behind you as we do so. So thank you again. Now we have the opportunity for some questions. There has been some questions in the question and answer page already, which some of Dinesh has already answered. And some of the questions we've got people when they registered, they provided with questions as well. Some of them are quite specific around the healthcare system, and I might just come to you, Dinesh. We had some questions around in Queensland now. We have the disability liaison scheme or system where medical centres and hospital have a specific disability liaison. I'm not sure whether it works in other states or whether it's working well here in Queensland. I know it's only new. But do you think, Dinesh, that that's something that can work, could work better, and would reduce some of the issues of not having equal access to healthcare, at least having someone that might have an understanding in those initial stages, particularly in the hospital system
Yeah,
or medical
definitely.
centre system?
Actually, I haven't heard of it being rolled out in Queensland everywhere. We certainly don't have one yet at Gold Coast. But the centre that really did some pioneering work on this is the Alfred in Melbourne, and they're publishing some of their data on it. And it's been a real success. It's reduced the amount of time that people with disability need to be in the hospital, in emergency departments. They can get the equipment that you need. In our hospital, we have a someone who looks after patients with spinal cord injury specifically. So it's a nurse that gets around oh, look, there's a disability liaison officer from Melbourne listening in. Hi, hello, Karen.
There you go.
This particular nurse has been great because whenever a patient with a spinal cord injury comes in, we can give them a bus and they make sure that there's an air mattress in place and they get all the equipment and make sure that the carers are provided for. So there's a lot of benefit that we're seeing from having someone, but it needs to become a state.
Thank you, Dinesh. The only reason I thought it was a bit more advanced in Queensland because I keep seeing the jobs advertised and keep thinking, oh, okay, so they've advertised them, so there must be a few more out there. But I wasn't aware they were in Victoria. But I think it's one of those things that it certainly couldn't hurt the situation, and at least if you know there's someone there that might have an understanding of what your specific needs are, other than trying to keep convincing the medical staff about what you do or you don't need.
Yeah, definitely. And I think we've seen liaison officers for other requirements in the hospitals work quite well. It's something that we're pushing for. And I think the evidence that the Alfred is going to publish will be really useful for other hospitals and states to advocate for this resource. There's always the questions about funding and everything like that. But I think one of the things that I have learned is that we need to be able to talk to all corners to try and get these arguments across. And what we say to hospital administrators, actually, look, if you invest this small amount in having a couple of people being liaison officers, you're going to reduce your overall costs. We got to talk to people in that way sometimes too, right? To try and realize our rights. So hopefully this will become a more widespread thing. We're trying.
Yeah, great. Thank you, Dinesh. I have another question, which maybe Yi and Jordan might have a crack at. If we look at the intersectionality of disability, First Nations peoples, LGBTIQ plus peoples, or people from non-English speaking background. Um, are we doing enough to ensure that their health needs are met within the system? Or if you add disability into that mix, are they more likely to suffer inequalities or less access to the system?
Yes, I think that's a good question because in another program of research I'm currently doing that we did find that when disability intersects with other disadvantages people experience in life, like socioeconomic disadvantages or gender, or living in rural and remote communities. So when these things happen together with the experience of disability, people tend to have lower access to the supports they need. And the potential reasons, as the qualitative studies our colleagues have done before, suggest that people don't even know what they are entitled to. Say, for example, people from culturally and linguistically diverse background, they don't understand the rules. They don't know where to get supports or where to how to navigate the complex health system. So that adds another layer to the disadvantage they are facing.
Yeah,
Yeah.
yeah.
Thank you.
I would agree. I would agree wholeheartedly. I would also say it's one of those things where we but we know that the vast majority of us as disabled people are like, we have more than one identity, where we are, and nearly always, with very few exceptions, we belong to communities or live in locations or are part of demographics that struggle to access the healthcare system before you add disability into the mix. So no, we're not doing it nearly enough, nearly enough. And if I could flip that on its head for just a moment, I had the opportunity to meet with Dilbul Yarragon, which is a First Nations health provider here in WA. And I spent a good hour and a half with their team and really got a deep understanding of the different ways that they provide services to First Nations communities, including First Nations disabled communities here in WA, through a community health model, through the Aboriginal community health model. And there was a point right towards the end where it really hit me hard that that so much of the service delivery model and the ethos, if you like, was not only vitally necessary to deliver healthcare successfully for First Nations communities, but what was actually just best practice in the delivery of healthcare, full stop. One of the things that they don't do is they don't have really booked appointment times, because that's not really how First Nations community healthcare works. If people are in front of you, while they're in front of you, you get them as much healthcare as you can. You book them in for as many things as you can, because there's all of these different intersecting reasons why you can't just kind of open your black book in a majority of cases and go, oh, wonderful, I'll book in for this time and then I'll turn up at, that is actually, something that is not possible. And so too for many members of our disabled community. Between the inaccessibilities of the public transport system, the impacts of neurodivergence and intersectional and compounding trauma, it would be much better to deliver disabled healthcare through a similar kind of prism. So not only are we failing to do right by these communities, but we're also failing to learn the valuable lessons that are taught when you try to deliver healthcare in those settings, that then can be useful for the entire system. Now, I actually have a kind of hard out at what was 5:30 here in WA. so I might have to jump off at this point, or unless there's one very quick last burning question. I'm so sorry. I usually can hang around a bit longer, but not this evening.
That's okay, Jordan. Thank you so much for joining us. We really, really appreciate your time. If we have any specific questions left over, I will make sure we get them to you, okay? And you can
All
get
right.
them at a later date.
Fabulous.
Thank you so much, Jordan.
much.
We really appreciate your time.
No worries at all. Thank you so much for the invite. And particularly if you're sitting online and you've got any lived experience of the challenges of accessing dental care, we are collecting stories at the moment to make the case for these changes. So please do send them through to my office at my email. It says senator.steelejohn@aph.gov.au. I'm sure Jeremy can pop it in the chat.
Thank you so much, Jordan.
Fabulous. See ya. Bye.
Mandy, I have a question for you that you may be able to answer that came through on registration. So with your course that you're running, I'm wondering whether you use the social model of disability in that course on that understanding, and whether when you deliver it, there are people that don't have a true understanding of what that means, health professionals, if they kind of go, oh, okay.
Yeah, look, we have had some feedback. So it's an online course, so I don't have face-to-face feedback. But yeah, we do frame it around the social model of disability. We go a little bit further and talk about the the biopsychosocial model of disability as well. And then we progress right from the start back to where it was the spiritual model of disability. So I actually do believe that people are understanding the importance of the social model of disability. The problem I find, though, and it comes back to the societal attitudes, is the people that do the course are already a little bit aware and interested. So it's the
Teaching to the converted
yeah,
already.
almost. Unfortunately, that's the way it is. But yeah, it's a big problem. So in answer to your question, I don't think there's a huge surprise about the social model of disability, because they're already halfway there. So yeah.
So how do we get your program mandatory and compulsory across all all, all facilities across the country?
Yeah, look, isn't there, Dinesh? It's a really big push on it, and Queensland Health, it's not mandatory yet, but they've put it on the highly recommended sort of list, and they've just implemented a bespoke version of the Access for All course. So it's on the way. There's a whole lot more to happen for it to become mandatory. But yeah, I believe that the people in the know and the people that are interested are starting to listen and starting to realise the importance. But as we said, there's still a way to go with that.
And just a quick follow-up question. Someone's asked whether non-medical people or non-allied can do the course.
Yeah, absolutely. It's really for anyone who works in the healthcare systems, but we've actually in healthcare systems, so they can be reception staff, administrators, cleaners. We've also had some vets do it and some people from the transport industry do it. So the content is relevant for anyone who works with people with disability. It's just got a little bit of a specific focus on health provision, of course, because that's what it was about. But, the concepts and the societal acceptance and those sorts of things are the same no matter what industry you work in. So, yeah, anyone
Carol,
can do it.
sorry, thank you, Min.
That's okay.
Can I come to you? So can I make the assumption that you receive funding through the NDIS? And if so, if you were hospitalized, would you think you should be able to use that funding in the hospital system, or should you have to use that in the hospital system? And do you have, if by some chance you had to re-enter the hospital system for a period of time now, are your are your are your fears stronger, less, more concerning now than perhaps they were 20 years ago? Or would you feel that it might be a better experience now, either because or not of the NDIS funding?
I've no doubt that I've got trauma as a result of my hospital visits, and Dinesh can attest in the first half of 2024, I had no less than 7 emergency visits to GCUH. It triggers so much. And because a lot, whilst I'm focused on my current care at the moment being very good, I have also experienced some very, very horrible experiences. And in current day, like my experience in the hospital environment has not been time of injury and then recent. There's been ongoing the whole time, you know, through obstetrics and then through pressure care. I spent time at the PA, in their care, and more recently with all the issues I've had in 2024 and ongoing. It is traumatic. If I was to look at, I am an NDIS participant, and so it depends on the situation case as to whether I want my support worker as opposed to, say, someone in the hospital environment and using my funding for a support worker. I absolutely do think I should have choice and control. With the current case of going for my breast screen, my absolute go-to was to want my husband to be the one to be manipulating my girls around the pressure machine and helping where need be, all right? And he was willing to arrange with work, and they were accommodating and all the rest of it. But in a hospital setting, there are certain things that a quadriplegic that is incontinent, doubly incontinent, is going to feel much more comfortable around choosing their own support worker than someone that knows them so well, than receiving that sort of care from a complete stranger. And that stranger will awkwardly, well, they might have years. I often hear this, oh, don't worry about it. We have years of experience and we do it every day. Well, that's all well and good for you, but I don't deal with it every day with a stranger. And it's new to me and I'm not coping with it. And my choice and control would say X, Y, or Z. And I absolutely do believe that should be funded. So it really does come down to choice and control as a participant, and not to be afraid to be vocal about what your choice and control is. And even to the more serious, senior in the hospitals. I was in a private hospital recently where I experienced a side effect of spinal cord injury, which is common, called autonomic dysreflexia, and it affects my life. It really does impact my life. And I was taken at 2 o'clock in the morning to this private hospital, and I was in the cardio ward, and I tried to explain, got out my little card from the PA hospital explaining how to treat AD and what to do. And the nurse, the head nurse her answer to me was, you are in the cardio ward, love. And there's nothing you can teach us that we don't already know about pressure care, about blood pressure. So I was taken aback by that, and having waited several hours just to get on a bed, discovered that the mattress that they brought me was not a pressure care mattress suitable to cope with a spinal cord injury. And we had a shot at it, and the moment I got on the mattress, my BP shot from its usual 90/60 to 190. So I spent the night in my wheelchair, having just agreed to put a fortune through my private health care. That was a very expensive Valentine's night and was not the hotel accommodation I was expecting. And Rob, I think, slept in that bed, and I got the wheelchair. And the next day we had to arrange for my support worker to bring in my own hoist and my own mattress for the next 4 days while I was treated with antibiotics for this sepsis condition that I was, not acceptable. So I complained to the doctor face to face, and I followed up with a formal complaint, and I received the letter of apology. I think we need more than that. I think we need to look at how private facilities are being accredited. how are they getting approval to build new facilities if they are building ultrasound, and mammogram image, not the ones that I had now, breastfeeding, that was a big, large room, but I have been in others that, and been told of others that, they're building in a broom closet. How are these being approved? There's a lot to look at. And at the end of the day, disability must never equate to people with disability receiving lesser than or lesser care, or a lower, most certainly a lower chance of survival, as he had so brilliantly set out for us. I hope that answers the question.
Yes, thank you. Thank you, Carol. Thank you. It certainly reminds me of my last two situations where I had to go to hospital. I was supposed to be overnight one, and one other was after autonomic dysreflexia. The first one I talked myself out of and talked the hospital out of keeping me in there overnight, and went home because they didn't have what I needed. And the second one I also took myself out of, uh, took my way going home because I said, I can do all this at home, you can't do it here. Both because of the fear of not being treated the way I needed to be
Yes.
enough. Neither of those were safe, but they were safer.
Yes.
Look, can I just thank everybody tonight? Can I thank you, Carol? Thank you, thank you, Mandy, and Dinesh has had to leave, unfortunately. This has been insightful, it's been educational, and it's been really well needed. We could not have done it without you, and we could not have done it without our participants as well. Um, we so much appreciate your time and your expertise on this, both personally and professional. Um, and again, we just can't thank you enough. We will finish up. I've just had thoughts going through my head about whether we do some sort of follow-up with this, but I'll try to formulate those better over the next few weeks. Um, if there's any questions that we still think here that we could address to each individual, we might send those to you individually. But once again, thank you so much. We really appreciate your time. Um, and everybody have a great night, and I hope you've joined the webinar. I hope you've enjoyed the webinar.